Good afternoon. I want to welcome everybody to our final webinar for Navigation Series Heart Failure. Our webinar today is entitled Palliative Care and Heart Failure, Critical Conversations That Always Succeed. I want to take care of a couple of housekeeping things prior to introducing our speaker. To obtain nursing contact hours, you must have entered your license number at registration. You must be logged in individually with a unique email address to the webinar for the full duration of the presentation. No partial credit will be available. A nursing contact hours certificate will be mailed to you. After the webinar, you will receive an email link to an evaluation. For all disciplines except for nurses, a certificate of attendance will be printed after completing this evaluation. It is my honor to introduce our speaker for today, Dr. Tom Mosier, board certified in internal medicine and hospice and palliative medicine. Completed a residency at the University of Iowa, Des Moines, and a fellowship at Stanford University. Dr. Mosier is currently the CMO of HCI VNS, overseeing and providing bedside palliative care and hospice services for 35 counties in Iowa. His expertise is working with families and patients with serious illness and chronic disease to amplify their living through improved disease understanding and management and empowering them to make medical decisions as guided by their goals of care. I want to welcome Dr. Mosier and thank him for coming on today. Go right ahead.
Thanks so much for that kind introduction. Hi, everybody. Excited to talk to you today about a little bit from my world of palliative care. And I was asked to talk about specifically palliative care and heart failure. And I designed this talk in kind of 3 segments. The first segment, I want to talk a little bit about heart failure in detail and some of the burdens that come with it, some of the statistics that come with it, that sometimes are surprising for people to hear. And then I want to walk through a little bit about placing that juxtaposition of palliative care and the extra layer of support that palliative care can provide for in those with heart failure. And then I want to segue into a little bit of what I call primary palliative care, and in essence, equipping you to be palliative care providers, because we know there are not enough palliative care providers available in the United States to meet all the needs of those who could benefit from it. And therefore, we liken it to a general practitioner who will practice, say, cardiology and will see patients with heart failure, but when they need extra support, they will go to a tertiary provider of cardiology or a subspecialty trained cardiologist for that. And in palliative care, we know that we need to equip everyone in healthcare with the ability to provide primary palliative care. And that ultimately, then we as palliative care teams and providers will be more available for the tertiary or more complicated issues seen. So hopefully today you'll walk away with a little bit of knowledge of some of the tips and tricks, as well as some of the pitfalls of goals of care conversations in advanced care planning. So ultimately, this is a really important topic, and the reason I want to start off with statistics is this. It is not uncommon for me to encounter a wide variance out there in acceptance of palliative care and the utility for those with heart failure. In fact, I've met cardiologists who are widely enthusiastic about palliative care services, but I've also met cardiologists and other physicians who don't feel palliative care has a role with their patients. And I often hear one statement when that's the case, and that is, I don't feel that our patients die from heart failure, and therefore, I don't really feel like palliative care is most appropriate for them. And I have 2 concerns when I hear that statement. The first concern is this, that they're likening and associating palliative care with end of life. And although it is true that all patients in hospice receive care from a palliative care team, it is more true that the majority of patients who benefit from palliative care do so outside of the hospice benefit. In other words, the earlier upstream that somebody with serious illness or chronic disease encounters palliative care, the more potential there is to impact their life. And so palliative care is not always hospice care, okay? The second thing that concerns me when I hear that statement is that I often pick up the perception that congestive heart failure is no longer a terminal illness, that it is, in fact, just a chronic disease. And I think that the data shows otherwise, and that in terms of which we can from the dialysis world is a significant when they're talking with their doctor. They automatically understand the challenges that come ahead, whether they're a healthcare professional or whether they're in the lay public. And ultimately, I would say more times than not, it's not uncommon for patients not to understand the significance of heart failure and, in a sense, have their expectations managed to some of the things that they will need to prepare for. But on top of that, it's not uncommon for providers to also kind of turn a blind eye to the burdens that their patients and families are facing. So with that introduction, I want to go right into the first phase of this talk, and that's going through some statistics. So first of all, congestive heart failure is widely prevalent, affecting more than 6 million adults in the United States of America, a pretty staggering number. And that there are close to a million newly diagnosed annually, 870,000 people. The average one-year mortality at diagnosis is close to 25%. And I think that that's a really surprising statistic for many of us to consider, that almost a quarter of the patients at diagnosis will die in the first year. Furthermore, 40% of those who have been hospitalized for congestive heart failure exacerbation will die within 1 year of that first hospitalization. Again, fairly staggering. That's nearing almost 50% of patients after that first hospitalization. And then 80% of those with congestive heart failure who are hospitalized in their last 6 months of life. And so those last 2 points I want to draw out to you, that when a patient with congestive heart failure presents to the hospital, it's a very significant event. And it really should trigger a flag in our minds that this is someone who very well could have a high mortality rate, and no doubt has a high morbidity rate. And ultimately, therefore, may be prime ground to think about palliative care. So 1994 through 2004, the national death rate in the United States of America went down 2% because of all of the treatments. And this is for all comers, not just congestive heart failure. But ultimately, in that same time period, the number of deaths due to congestive heart failure increased by 28%. Now, I want you to consider that for a minute. That's fairly staggering. It does speak against that CHF is not potentially a terminal illness, okay? Currently, we spend about $32 billion a year in the treatment and management of heart failure, and it is felt that there's going to be an exponential increase by 215% by 2030 to $77 billion. And is that because the incidence of heart failure is going up across the population, or is that because of the baby boomer generation and the gross numbers? I suspect it's the later. So this is what's concerning and hard about congestive heart failure. It has a predictably unpredictable trajectory curve, and it's somewhat of a loaded statement. I want to break that down for you. So in palliative care, when I look at any particular chronic disease, I typically think of specific trajectory curves that you might expect. An example would be cancer. A patient who's diagnosed with an advanced cancer or cancer typically has a slow decline, but steady decline over the course of months to years as they are treated. And if they cannot realize a full remission and cure, then will eventually reach a point where their decline accelerates. And in a sense, it's almost as if the floor fell out, and you'll see the curve begin to take a nosedive down very rapidly. So typically it's accepted that with cancer, the trajectory curve looks like an upside down parabola that has a ever increasing slope of decrease in line. In congestive heart failure, though, we look at it as a sine wave. And the reason is because we know that from time of diagnosis through the course of heart failure, people have periods of exacerbation where they take a nosedive down and then remission, and they'll come back up. And sometimes plateauing to where they were before, sometimes not quite rebounding all the way. So you could say more accurately, it might be a sine wave with a slight downward trend in its slope overall. But typically it's stretched out over some time. The tricky thing is this: there are people that have a sine wave with a very high frequency and or very high amplitude of their wave, meaning they have very severe exacerbations with very high frequency, and they ultimately sometimes can die very rapidly and suddenly. And then there are others who have a sine wave that has a lower amplitude or a lower frequency, where their exacerbations may be further apart, their exacerbations may be less severe, they may have shorter hospital stints in between, or maybe they're able to just get managed at home and even stay out of the ER altogether. So ultimately, there is a wide variance in how people present, even though they all tend to have a sine wave function. And ultimately, there's a lot of reason behind that, because if you think about congestive heart failure, there are many, many different causes for it. If you break down simply heart failure into diastolic heart failure, an issue with relaxation of the heart muscle and compliance of the heart muscle, versus systolic heart failure, where it's actually a pump issue or a muscle issue, you can get a plethora of pathophysiologic states that cause each category. For instance, for diastolic heart failure, you could have somebody who's just had chronic hypertension and their muscle hypertrophies, all the way to amyloidosis and infiltration by protein that leads to that. And in systolic heart failure, you could have ischemic cardiomyopathy, where literally arterial vascular disease led to a traditional MI. And you can also have somebody who has a genetic heritable issue with their pump, and it's failing because of that. So ultimately, there is a plethora of reasons people have heart failure, and that in and of itself gives a vast trajectory curve distribution. On top of that, we have ever increasing number of treatments, both pharmacologically and procedurally, that can augment heart failure. Heart failure, truly, the trajectory curve can be augmented a bit by those. We know that somebody who comes in with a myocardial infarction, who has an ejection fraction of 25% after the MI, may not have that same ejection fraction after we give them pharmacologic management and we augment preload, afterload, as we basically help optimize the muscle through beta blockers, etc. So ultimately, we know that we can augment heart failure in many people. Then you can add to that comorbidities. Think about heart failure. Very seldom is it diagnosed in a vacuum, right? Patients have many other comorbidities: chronic kidney disease. They can have pulmonary disease, restrictive disease, COPD. They can have other disease states like cancer. The list goes on and on and on. And ultimately, every single one of those comorbidities is going to change and ultimately augment issues the heart may face. So it becomes extremely complex to prognosticate in a nutshell. And unfortunately, sudden death is not an uncommon presentation. So those patients who are doing incredibly well still are at risk of sudden death, just like the patient is who doesn't even know they have a heart problem, who has an event while they're exercising or doing something else. So ultimately, the treatment, the therapy, the wide spectrum of causes lead to a lot of challenges when it comes to prognostication. And really, as treatments and therapies have advanced, we do feel that prognostication has gotten more complicated and probably will continue to get more complicated. So I mentioned cancer earlier in the talk, and I just want to put CHF juxtaposition to cancer for a minute for you. because we, again, we associate cancer with a high burden of illness. And I think sometimes underappreciate the burdens with CHF. But if you look at this slide, you can see that those with congestive heart failure are more likely to spend more time in the hospital, in the ED, on the floor, and in the ICU than those with cancer, which is somewhat staggering because we definitely associate cancer with hospitalizations, complications, etc. Unlike cancer, like I mentioned, congestive heart failure prognosis can shift around on the trajectory curve. And so ultimately, medical management is very important. There is a time and a place for aggressive medical management. It's the leading cause of morbidity and mortality worldwide. 5-year survival of about 50%. In those with multiple comorbidities, the 1-year survival is quite dismal. And I want you to think about your average patient that you encounter with congestive heart failure. It is very common, and I would say very expected to see other comorbidities involved. In fact, it's very rare you see a patient with just congestive heart failure and no other comorbidities. When we talk about heart failure, we can classify it based on the New York Heart classes. And ultimately, you can shift up and down a New York Heart class because it's really talking about the symptomatology that you face at a time and place, which can change. But ultimately, when we stage it, stage A through D, stage D heart failure are those patients who are optimally medically managed and aggressively medically managed who still are symptomatic. And so there's a lot of those patients out there, and their 1-year mortality is close to 30%. 1-year freedom from hospitalization or death is only 30%. Median life expectancy for 6 to 12 months is quite low. And there's extremely high symptom burden and poor quality of life. Now, if you're thinking about how could we actually predict who has the highest mortality risk, there are studies looking at that. And ultimately, number one, age. So when you have a patient that's elderly with heart failure, their mortality risk is significantly higher. Number two, if inter-hospital or post-discharge brain natriuretic peptide, BNP, is elevated, meaning we've tried to optimally manage them, right? They're in the hospital, we've done everything we can do, and the BNP is still up, or we've just discharged them and it rises again. That's not a good prognostic sign. That tells you the heart has kind of reached the end of its plasticity, and you just don't have much wiggle room or buffer before things decompensate again. Low systolic blood pressure can be a key. Ultimately, we know the heart's a pump, and if the pump can't produce pressure, that's the first sign that the pump is failing. So if we have the systolic blood pressure low, that is a risk factor for higher mortality. High heart rate at 1 or 4 weeks post-discharge. So again, as the pump pressure goes down, the heart tries to compensate for its failing contractility by increasing the rate, the number of beats per minute, so that we can get that flow increased. And ultimately, as we see the heart rate go up, it's a trigger that the heart is failing again. Prolonged QRS is another thing associated with increased mortality. Hyponatremia, so remember, from the kidney's perspective, when the pump is failing, they're not getting what they need. And so selfishly, they retain salt and water to try to increase blood pressure. But they haven't communicated with the heart, and what that does is it makes it harder on the heart. And eventually you can dilute down the plasma and end up with hyponatremia from that volume overload state. So as we see that sodium fall, again, that's an indicator that the patient could be closer to end of life than realized. And I'll tell you what, it's not uncommon to get a consult and see somebody with CHF and see hyponatremia as an issue. And then lastly, baseline renal impairment. And given the fact that the kidneys and heart really need to work together, when somebody's renal function's down, it can become a seesaw of terror for a patient, because ultimately you diurese some and the kidneys crump, and you don't diurese them and the heart crumps. So ultimately, we know chronic kidney disease, baseline renal impairment is an indicator of increased mortality. So you take all of this that we've talked about and you throw it in a bag, and what do you end up with? Well, ultimately, what the literature finds and what we've found as we've continued to delve into CHF with palliative care is that there tends to be a focus on unending medical interventions when CHF is end stage, rather than a shift in focus on quality of life and advanced care planning. So we found that physicians are less likely to have goals of care discussions with patients with heart failure than those with advanced disease. And really it comes down to this buzzword of prognostic paralysis. Any time that we're not really sure the trajectory they're on and what the prognosis is for them, you definitely want to do right by the patient. You want to try everything possible. And so it becomes very uncomfortable to talk about advanced care planning things. It becomes very uncomfortable to talk about the potentials for mortality and morbidity, because ultimately you don't want to scare the patient if it's unnecessary. But I would tell you what I've learned as I've worked with countless people with heart failure is this: you can predict the trajectory, and frankly, it's in any disease. You can predict the trajectory most accurately by looking at the trajectory that came before. So if you watch the pattern of a patient and you see those high amplitude and high frequency waves in their history, then it is reasonable to assume that is going to continue. And so ultimately, it is so important that we talk to patients upstream. And in fact, I would argue this: even if a patient is years away from end of life because of heart failure, they would still benefit tremendously from heart failure, palliative care and heart failure, because of the burdens that come anywhere along that trajectory curve. In other words, the thought that heart failure is a benign condition that is held by so many, both in healthcare and in the lay public, it really isn't true. Patients overestimate our capabilities, and they overestimate the power of the technology we have with ICDs, CPR, LVADs. Those are just naming a few. We could really make a pretty long list as we talk about some of the things. There is a time and a place for each of them, but the impact that's made the further downstream you get begins to get smaller and smaller in the increments as far as quality of life. And most patients with heart failure in the end don't understand the mortality risk. So let's shift and talk a little bit about the burdens. Number one, let's talk about symptoms. We all have taken care of plenty of people with heart failure, and we know dyspnea is right on up there. Shortness of breath, trouble breathing, both because with left heart failure, the lungs become edematous, and therefore the DLCO, diffusion of through the interstitial space, restricts oxygen, but on top of it, the lungs get stiff, and the stretch receptors and everything else in the lungs fire and tell them they're not breathing right. We know that pain is actually associated with heart failure, and that might surprise you. But there's studies looking at patients with heart failure, and there is a high prevalence of pain, particularly in the lower legs, both from edema and what chronic edema does to the nerves with neuropathy, as well as skin breakdown and wounds, and even cellulitis. But ultimately, neuropathic pain is not uncommon in heart failure in the legs. Certainly, we also know that any patient who's bedbound has much more pain, both from arthritis and also just positional things. Nausea. We often don't associate nausea with heart failure, but believe it or not, it's very prevalent. The reality is we all recognize that as the pump fails and the right heart begins to fail, everything backs up downstream, right? It's the infamous analogy of the sump pump. The pump's failing and the basement floods. That includes the basement of the liver and then the splanchnic circulation. So you can end up with significant bowel edema, which leads to malabsorption, contributing to issues with nutrition and anorexia, but also nausea. We know that as people continue to lose their independence and continue to have symptomatology and need for hospitalization and bills and everything else that you see below in this slide, anxiety and depression go through the ceiling. So very prevalent. Fatigue is very self-explanatory and very prevalent. And then also insomnia. So those are just a few of the symptoms, and we could really continue to build that list if we wanted. Next, existential suffering. So this would be what heart failure does to the psyche and the psychosocial, spiritual aspect of the patient and their family. When you consider the lost freedom and independence, the lost relationships as you become more isolated or depressed, the lost status and social roles, and time to work and be free. There is a humongous burden that congestive heart failure places on patients and families and caregivers. And then lastly, financial stresses. And we could literally talk for an hour just about the financial burdens of this disease. When you think about lost income, when you think about the cost of just one hospitalization or ICU stay, when you think about the medication costs and the medication cocktails, which, you know, again, medications have revolutionized the treatment of heart failure and are so worthy of being prescribed and taken, but there are significant drug costs and co-pays and time spent driving to get drugs at the pharmacy. The cost compounds over and over. So financial stresses are huge. So we've kind of walked through phase one here and laid out the foundation that I hope, if nothing else, the take-home point that you can see here is that congestive heart failure has a tremendous burden for those who suffer from it, whether they're just diagnosed, whether they have more mild to moderate or severe disease. There are significant burdens for all of them along the way. And that's where palliative care comes in. So first of all, definition, to palliate means to hide, cover, cloak, mask, disguise, camouflage, okay? And so in palliative care, our goal is to make the disease or symptom less severe. And sometimes that's really without removing the cause. Most of the time it is. With chronic disease, the reason it's chronic is because we know we can't cure it. But ultimately, the idea of palliative care is to surround the patient with a multidisciplinary team to be able to elevate their quality of life in any way possible, to mask these burdens and suffering and symptoms that they feel. And that's really to amplify for whatever amount of time they have to live. You probably all have worked with palliative care teams and are well aware of the different disciplines that can be involved in palliative care, and it's different depending on which team you're counting and which hospital system or private system has developed a team. But it can include physicians, nurse practitioners, nurses, spiritual care counselors, or chaplains, social workers. Some palliative care teams even have physical therapy, occupational therapy, massage therapy, music therapy. So it's going to differ depending on the system you're in. But the idea is this: a patient is not their disease. A patient's sort of like a diamond. A patient has many facets to it, and what makes them beautiful is the compilation of those facets. We all are a compilation of not only our health and wellness and our illness, but we're a compilation of our spiritual beliefs. We're a compilation of our values, of our goals, our dreams, of our skills, of our accomplishments. And ultimately, when a disease strikes a person, every facet takes a hit. And that's why the more people involved in the palliative care team, the more you can surround that patient and identify how to right those areas of stress and duress on those areas of their life. This is a great graph, I think, that describes palliative care beautifully. The old system, we would provide life-prolonging care in congestive heart failure up until they either died or were felt to be imminently dying. And at that point, we would enroll them in a Medicare hospice benefit or their insurance policy's hospice benefit, and that's what we gave. Today, what we are continuing to strive for is that at diagnosis, they may encounter palliative care or very shortly upstream from that. But ultimately, you can see initially the primary team is going to be the main workhorse for them in their chronic illness. And palliative care is just there for touch points and to help guide and to help assess if there's any needs. In essence, the goal of palliative care is to be an extra layer of support to the primary team and an extra layer of support for the patient and family. But as that illness progresses, as we expect with any chronic disease, palliative care will begin to become more and more involved because likely the symptom burden or the burden on their life is going to be more and more complicated. And ultimately, palliative care will continue to be aggressively involved up until the point that we feel they may actually be in their last 6 months of life. And at that point, palliative care transitions to a palliative care team under the hospice benefit. And at that point, it doesn't end, because the reality is, integral to palliative care, integral to hospice, is bereavement services for the family. So ultimately, the patient is always the focus of care, but the family is always in the ombuses of care of any palliative care team, whether it's a palliative care team at end of life in the hospice benefit, or whether it's a palliative care further upstream. So the bereavement piece is integral to this diagram. So I bring you back to the burdens and the symptoms. I want to talk to you a little bit about what palliative care has shown in the last year. So the palliative care movement has continued to grow and accelerate, and the body of literature has grown exponentially in the last 10 years. When I was in medical school and I worked in a work study in hospice, I was so naive to what palliative care was. I thought it was hospice, and I thought it was about resigning hope and dying. And ultimately, since then, I've learned it is nothing like that at all. This research has helped show that. In 2007, there began to be multiple publishings of how patients, even getting palliative care in hospice, were living an average of 29 days longer than those in similar non-hospice patients. And it began to catch people a little off guard. Most people associate hospice with dying sooner, but that didn't seem to be the case. That same year, data showed that hospices ultimately also were associated with increased quality of care and actually cheaper care, more efficient care, and more fiscally responsible care. And that ultimately then, in 2010, another article hit in the palliative care world, and those who weren't in hospice. And it looked at those with early non-small cell lung cancer, and it randomized them to a group of traditional oncologic care versus traditional oncologic care with palliative care following along at touch points along the way. And ultimately, they were looking at primary outcomes of quality of life, depression scores, et cetera. But what they found is that those who were getting palliative care team to help guide them, they were living on average 2.8 months longer. And that shocks the medical world. But I think if you think about it, it makes a little bit of sense. I think we would all agree that a patient is truly informed about the risks and the benefits of any treatment offered to them may just end up not picking the Hail Mary that has very little chance of being caught and helping them and a lot of chance of being missed and harming them. And so ultimately, when patients are truly informed, they often choose much, much less risky and aggressive measures that really shift the help to harm ratio to a very small number. So ultimately, this was fairly groundbreaking. And since this time, we've had numerous other articles hitting, looking at the benefits of palliative care, and therefore have seen tremendous growth in the palliative care sector, with hospitals desiring to be palliative care centers of excellence, and CMS looking towards how to incorporate palliative care even into the hospice benefit in something we call the care choices model. So ultimately, a lot of momentum began in early 2000. And now today, if we focus now on heart failure, just last year, numerous studies were published. I grabbed two of them for you here. There was a study looking at a group of patients with CHF who received palliative care. And in that, they found 100% of the patients and families had a strong appreciation for the role palliative care played, meaning it was meaningful to them, both 48 hours after the consult and 6 months later post-discharge. 63% of them reporting that they had a significant change in how they thought about their illness. Okay, so they felt tremendous value. Another study, which actually then looked at, well, what about the impacts actually on disease and quality of life? And ultimately, this was the PAL-HF, palliative care and heart failure study. And this study looked at 150 patients, and they randomized them very similar to that early non-small cell lung cancer to traditional treatment in a heart failure clinic versus traditional treatment plus addition of palliative care at 6-month intervals along the way. It ultimately found significant improvements in disease-specific and general quality of life measures in that study, as well as statistically significant improvements in secondary outcomes of mood, well-being, depression, anxiety, spiritual wellness, etc. So ultimately, showing again that patients do value palliative care, and there is a measurable impact on their quality of life and their perception about their illness. So I'm going to take a minute now to just shift gears and think about important decisions that you've made in your life. When any of us buy a house, the average person looks at 30 homes before they make a decision. The average person loses a lot of sleep on the night before that decision and has quite a bit of angst, both when they're signing closing documents and after they've signed them. And the reason is this: we know that a house is a massive purchase. It can jeopardize 30 years of your income or your well-being. If you buy a lemon that has a bad roof and a bad furnace or problems with rats or termites, it could bankrupt you. If you buy in a neighborhood that turns out to be not as nice as you thought, with a drug dealer next door or crime, the value of your home goes down and your well-being and safety are jeopardized. If you ultimately work too hastily in buying a home, it can have catastrophic outcomes on your life. And so we do our homework when we are making a decision about a purchase of a home. Likewise, we do the same, frankly, with a car. Now, all of us would agree car is not near as big of a purchase as a house. Well, I guess it's depending on the car you're buying. If you're buying a Tesla, maybe. But ultimately, a car doesn't even compare to a home as far as decision, but we all do our homework on our cars. Very few people walk to a car lot, grab a car without doing any research, because again, it's a major financial move. We're talking about our safety on the road. We're talking about reliability. We're talking about something that we can't just backpedal from. It's something that depreciates pretty quickly. It doesn't hold its value very well. So ultimately, when buying a car, we really, really do our homework and we think hard about the decisions we make. Now, I want to place that juxtaposition to healthcare. How many of you have been in a room when a very, very sick patient is asked if they would want CPR, if they'd want their heart restarted if it stopped, if they'd want us to breathe for them if their breathing stopped, and are asked to make that decision in the first seconds of a very long conversation as they're being admitted. And I want you to think about that for a minute, because nothing is more sacred than someone's life and well-being. And when they are sick, we are asking them to put something far greater value on the line than their finances, and we are asking them to place the rest of their life in our hands and our trust. And so that is a very big decision. And I want to walk you through an illustration that I often give that I think highlights the pitfall that can happen when people are asked about preferences rapidly in making medical decisions. So I want you to think about, if you were to take a trip, would you want to drive on a road that looks like this or this? Or would you prefer to drive on a road that looks like this, this, or this? Now, if I ask for a show of hands, I am confident that 100% of you would have picked the first two roads. And the reason I can say that is I have given this illustration to countless audiences of different sizes, of different mixtures, physicians, nurses, lay people, and everyone instantaneously knows what they would choose. But now I want to add a little context, because thankfully I know what your preference is. And so the context is this: you live in Iowa and your father lives in East Lansing, Michigan. And you just got a phone call that he was in a serious car accident and he's not expected to survive more than the next hours to several days. You're panicking, you're shocked, you need to get there, and you need to find somebody to cover your shifts, your call. And so I, as your friend, since I've had an advanced care planning, so to speak, discussion with you, I am going to get a bus for you, and I'm going to get you to your dad. And this is the route that I picked for you. I'm going to bring you through one of my favorite drives, and that's right through Wisconsin and through the Upper Peninsula, Michigan. It's gorgeous. I'm going to bring you across the Mackinac Bridge, a 5-mile suspension bridge, which is a natural wonder, and through northern Michigan down to East Lansing. Now, if you're lucky, you'll get there in 15 hours, but realistically, with bathroom breaks and eating and maybe hitting a few deer along the way, you probably won't get there in 15 hours. I could have routed you right south of Chicago through Hammond, Indiana, Gary, Indiana. I'm pretty sure those last 3 pictures came from that route. It would have only taken 8 hours, but I know that is not what you would have picked based on your strong and confident preference when I asked. So now I ask a question of you. How many of you are disappointed and upset with the decision I just picked? And I'll tell you again, I'm going to assume that 100% of you are, because I've never seen the audience not raise every hand when I ask that question. And so I always find it intriguing that so rapidly everyone knows exactly what they want, but then so rapidly it's exactly wrong. And my question is always, how is that? And I would submit to you that the reason that is because initially all I asked of you was a preference. And preferences are kind of similar to pie in the sky, right? It's kind of hope as a plan. It's kind of utopia. But when you add context and you put your values into the context of what's going on, you suddenly will get different responses. And so I often say that if you submit people's preferences without adding the context of their illness, helping them understand the pros and cons of any treatment, the risks, the benefits, helping them understand what's really going on, and you don't elicit what's important to them, you are putting them at very high risk of regret. And I would argue that in heart failure, there is nothing more sacred than someone understanding the context of their illness, because it is so complicated. So now I want to shift into a little bit of primary palliative care for you. So advanced care planning discussions, goals of care conversations, advanced directives, they're critically important to have these discussions with patients with heart failure. But it's really scary to do it. And a lot of times people have no clue where to start. So I'm going to give you my secret sauce. And my secret sauce boils down to this. If you can remember, ask, tell, ask, you can do these conversations. Because after all, we all know how to talk to people. That's why we were drawn into healthcare. The first thing that I do with any patient basically boils down to this. Tell me what you understand about your illness. And as you notice, it's a very open-ended question. We'll talk about open and closed-ended questions in a bit. It's a very open-ended question. I'm inviting them to talk. I want to know what they know. I want to know what they think, both what's correct and maybe their misperceptions. And frankly, sometimes they tell me I'm clueless. In fact, many times they tell me I'm clueless. I literally had a gentleman referred to me last Sunday who fit in this box. He was on a milrinone drip. He had an ejection fraction of 15%. He wasn't expected to live even on the milrinone drip. And he came to me in a hospice scenario and had no idea that he was near end of life, and had no idea that he had been near end of life for a long time. So tell me what you understand about your illness. This is the part of what we call shared decision making that is the most important. When we say shared, we mean shared decision between the provider and the patient and the family. We mean everybody gets on the same page together, and then the provider, who's like the co-pilot, the navigator, starts giving options for navigation, and the patient, who's the driver, they get to steer, okay? So that's the sharing. The sharing is you're a team together, but the patient ultimately chooses their direction. This is the most critical part, because this is the part that a patient realizes how much you care about them. The first time a provider says, I'm going to shut up now and I'm going to let you talk and you tell me, it's shocking, because we've done studies, and I'll just admit we docs are horrible at listening, okay? And just ask my wife. I'm not any better at it at home than I am at work. So it doesn't come naturally. We have to practice it. The second is tell. So after the patient, after you explore and everything they understand and you probed into what do you understand about your medicines? What do you understand about what you're here for in this hospitalization and what they're hoping to accomplish? Whatever form you want to ask it in, that's the point to say, would it be okay if I shared with you what I understand after talking with your subspecialist and team, after talking with your nurses, after looking through your chart and your history and your other hospitalizations? And at that point, because you've done your homework, you can speak then with eloquence to the things they understand correctly and maybe answer some of the gaps that they put out there for you that they didn't understand, or clarify some areas where they're a bit confused. This is the opportunity now to get them and you together on the same page. And then last, after you tell, you ask again. You may have given some bad news, and it's totally acceptable to say, does it surprise you? Does it scare you? Does it shock you? Is it hard for you to hear that? Or ask, having heard all of this, what's the most important thing to you right now? What do you hold most sacred? What do you think you want to do? That's, again, a very important thing because, again, it's showing them that this is about them, that this is patient-centered care. It doesn't matter what you think as the provider. It doesn't matter what you do as the provider. It matters what they think and what they would do. This is just an example of a protocol that you may see in palliative care literature called the SPIKES protocol. And it speaks a little bit more in detail. As you can see to the right, I kind of labeled the ask, tell, ask phase. But ultimately, definitely make sure that when you're having these conversations, you're prepared. Number one, you've done your homework and you know their history. Number two, that you have a good surrounding. You're not in the middle of a busy waiting room, that there's privacy, that there's Kleenexes, that you've invited them into this, and that you understand what they would want to know and what they wouldn't want to know. Some patients don't want to know the bad news, and that's okay. Okay. So ultimately, the SPIKES protocol, if you like acronyms, may be more helpful, but ask, tell, ask, I think, is a more simplified form of that. Use open-ended questions versus closed-ended questions. Don't say, do you understand what CHF is? Because you're liable to get a yes, but that doesn't tell you anything. Say, tell me what you understand about your illness. Do you think you are getting better or worse or about the same? And tell me what information you're using that you think that. So you're giving them a platform to just talk and tell you what they're seeing. Words in this case are going to help more. Have you gotten a sense from your doctor on what to expect going forward? Is a great open-ended question that can help lead into where the questions, concerns, worries, fears, you name it, are loaded. Here's some advanced questions you could ask. They're kind of strategic questions, a reflexive question. What do you think would happen if you were to stop your medication, or if you were to stop dialysis, or you were to stop? You can explore what are their fears, what are their wonderments, what are the things that they have correct and or not. What benefits do you think might come from stopping these things? So shifting it a bit, what benefits do you think might come if you didn't have dialysis every day because of your poor kidney function superimposed on your heart failure? Strategic questions. What change do you think might help indicate it's time to stop X, Y, Z? Okay, you're not saying you need to or you don't need to, but what change do you think? What is your perception of that? What change would need to take place before you be comfortable stopping? And that can help you get a sense of how they're looking at their illness and where they're at. And frankly, you have to know where they're at to be able to meet them there, right? Definitely, we kind of talked about preparing. You need to review records. You need to talk with the other healthcare team, help them to know you're there to support them. You need to know what they feel. You need to really plan for these meetings and do your homework. And then ultimately, tips for the conversation. It's not bad to sometimes give a warning shot. I'd like to talk to you in a fairly detailed way about what's going on, and is that okay to do? Again, that permission really is an engaging thing for patients. Avoid medical jargon. I talk a lot about sump pumps. I talk a lot about soaker hoses that leak when I'm referring to blood vessels in the lung or the legs or the liver or the intestines. So come up with some good analogies that people can understand. This picture says 1,000 words. Watch what you say, not just with your mouth and your words, but your body. Everybody can tell this nurse is extremely engaged and this patient is extremely engaged. You can tell they're both at ease. You can see the therapy, and it communicates 1,000 words. Likewise, so does this spunky little girl who's trying to manipulate us right now, right? We can read body language very well. Learn how to control your body language, not to cross your arms or your legs or lean back. Lean forward, lean into the patient. Hold your arms in a very loose and non-threatening position. Sit down at the bedside instead of stand. We communicate 55% of what we say is communicated in our nonverbal language. If I read this, Mary, given the serious nature of your illness, I want to talk to you about what your treatment preference is going forward today, okay? Or Mary, given the serious nature of your illness, I want to talk with you about your treatment preferences going forward. Is that okay? There is a big difference in that, right? One would really torque you off. It communicates, I really don't care. I've got an agenda. This is just a checkbox in my day. The other communicates, I care, and I'm here with you. Shifting gears again, when we're talking about advanced care planning, every state is pretty much involved now in the PULSE paradigm. In Iowa, we have the Iowa Physician Order for Scope of Treatment, or the IPOST form. When you're having these conversations, make sure you have this form, because this is how you capture that conversation. If we just run through this form in a checkbox, we will capture preferences, and this form will be worthless or harmful. But if we capture that conversation we have on this form, if we make sure to hit on these things in that conversation, we have just captured power. So I want to conclude today with this statement, and this is a statement by Atul Gawande from Being Mortal. Many of you have probably heard this. I hope you've read the book. If not, I would strongly encourage you to read this New York bestseller. But he says this quote, which I think sums up this talk perfectly. Whenever serious sickness or injury strikes and your body or mind breaks down, the vital questions are the same. What is your understanding of the situation and its potential outcomes? What are your fears and what are your hopes? What are the trade-offs you are willing to make and not willing to make? And what is the course of action that best serves this understanding? I hope in this talk you have been impressed with the incredible need to make sure we don't just draw a blind eye when we see CHF in a chart to it being a lightweight chronic disease, but that we understand that it has serious risks and burdens on patients and families, and that we can do tremendous help to them and support of them through primary palliative care, tertiary palliative care, and helping meet them where they are at as a human being. Thank you so much for your attention. We have about 5 minutes for any questions, if there are any.
This is Jennifer. Feel free to type in the chat. Otherwise, I am going to unmute people. So if you want to be muted, make sure to do that. Not everybody at once, please. Okay, I don't see anything coming in right now, but I will say that you did an excellent job of really tying all of those pieces together. We have a comment in the chat from Jing from IHC. Thanks a lot, Dr. Mosier. The presentation is very informative. So thank you for that, Jing.
Yeah, thank you.
Yes, this was an excellent presentation. I think that you really hit us really excellently at the beginning with a lot of cold, hard facts. And I think that that's really important for people to put into perspective and actually have right in front of us. But you also touched on a lot of the misconceptions about what people may think hospice care or palliative care can do for patients, which I always love when people clear up misconceptions and clear up anything that may be perceived in a certain manner. So really pulling out those definitions and using Webster's dictionary the best we can is always excellent. So thank you for doing that. The other thing that I really appreciated was really pulling out some of those barriers of having those conversations. What does that look like? Why are patients and families feeling the way that they are? And really talking about some of the symptoms that are associated with that. Within TCPI, CMS really promotes patient and family engagement, and shared decision making is a huge portion of that. I feel like a lot of doctors and a lot of clinics say, yes, we do shared decision making, and then when we ask them what an example of that is, sometimes it's crickets, or it's like, oh, well, I don't really think that was shared decision making. And I think you really highlighted how to do that, how to really do shared decision making. And it's not always about the words that are coming out of your mouth, but it's about the way that you're saying it, or the posture, or all the nonverbal cues that makes it an open conversation rather than a statement. So I really appreciated when you not only said that, but then you gave an example. So thank you for that.
Yeah, I tell you, it's probably the easiest part about it is just remember what you would want. It's projecting what you would want in your provider onto your patient, and just remembering that you're human just like them. And the minute that they see that you're talking them one human being to the other, they let go of their fears and they open up to you, and that's where you can really help someone.
Yes, and creating that comfortable environment as well is just so important. Oh, the one thing I did forget to touch on is I really liked when you talked about all the different alternatives to medicine, where you were talking about, massage therapy and music and aromatherapy and all of those things, because I think that's a piece that's missing sometimes, especially when we're talking about like comfort scales and opioid usage and misuse. Really highlighting those alternative medicines is excellent. So thank you for touching on that.
Yeah, I take care of primarily patients in the hospice benefit because I oversee a very large hospice. But ultimately, I always tell patients they will not remember hospice for their excellent symptom management and medical prowess. Although it's there, and although we get high tech at times for symptom management, they will remember the people. And they will remember the music therapist, the social worker, the volunteers. It's the human side that makes the biggest impact. And honestly, I tell providers every day, telling a patient there's nothing more I can do for you is probably the most untrue thing you could ever think, because the reality is when a doctor who has turned their patient over to hospice, even when they're at end of life, comes in to just sit with them and hold their hand, that power of presence trumps every medical decision they've ever made for that patient. And at that point, a patient will not stop talking about the power of that visit. So don't forget the power that you possess in just being present.
Wow, yes, that's a very powerful statement, and I would agree wholeheartedly with being a social worker of 12 years prior to this. That is exactly what I would hear from clients and their families was that personal interaction. So definitely, thank you very much. I think we will conclude here. We are right about at 1 o'clock. We might have about 20 seconds left. I will open it up for questions one more time, just because I do know that we kind of just had a back and forth chatter during this last part. So I'm going to allow for anybody else to speak up if they would like. Otherwise, we'll be closing here in the next 30 seconds to minutes. All righty. I think everybody just enjoyed it. So thank you once again. If you are here in Iowa, Dr. Moser will be speaking at our HIN Learning Community here in September. So thank you very much for taking time out of your day to join us. And if you were watching the recording, thank you as well.